Hello, my name is Elliott Haut, and I'm going to talk to you today about improving VTE prophylaxis at trauma centers across the United States. You've heard a little bit already about the issue of missed doses of VTE prophylaxis, and that's what we're going to focus on today. We've had a big assumption that as physicians, when we order medications for VTE prophylaxis, they always get to the patient every single time. But the real question is that really true? Does medication prophylaxis prescription always equal administration? And the answer might be no. So why might that happen? We know there are key parts to VTE prevention in hospitalized patients. The first of which is ordering the right medications for the right patient at the right time. We're not going to talk at all about that today. But what we are going to focus on are the next two key steps. So the first of which is a nurse who gives the right medication to the right patient, and a patient who willingly accepts the best practice prophylaxis. We've been working on this project about missed doses and improving them since 2013, when we were initially funded by PCORI to start this work. And you're going to hear a little bit about the work we've done in the past and where we're moving forward with this. Our initial project had three key parts. First, we were going to work with patient and nurse communication and focus on improving the communication between the two groups. We were going to empower patients to take control of their prevention of blood clots. And we were going to then use these tools with an escalating or an active engagement of patients with a real-time alert. And I'll explain what that looks like. So the first part was, can we educate nurses about VTE prophylaxis, and does it matter? And the answer is absolutely a resounding yes. We did a randomized trial of nearly 1,000 nurses at Johns Hopkins Hospital and showed that one single session of online education for nurses decreases missed doses of VTE prophylaxis by about 13%. So we now have a standard education tool that we know works. By giving to nurses, we're going to improve care for patients. So that's one key piece we're going to talk about. We also created a patient education bundle because we wanted some enduring materials to be able to share with patients. So we did this by asking patients what they wanted, and we wrote this paper about it using two key stakeholders who are actually pulmonary embolism patient survivors as part of our team to help create these materials. And what patients told us was basically they wanted some combination of a person talking to them, they wanted paper, they wanted a 2-page handout, they spoke and we listened and we created this. You can come to the website and take these education materials for free. They're in English and a dozen other languages. They also wanted a video. So we created a patient education video. Here's the link. You can go to bit.ly/bloodclots and watch this video. It's got closing in on 250,000 views on YouTube. So for a patient education video, I think we're doing quite well. It has real patients telling their real stories in addition to some clinicians. So then we also built a real-time alert. So what exactly does that mean? That means that we know that in the electronic medical record, a nurse would document each medication as either given or not given, and the not given might be for patient refusal for other reasons, and that gets documented in real time in the electronic medical record. So what our alert did was it used that documentation to trigger, and we used a pager at the time, a notification that someone has missed a dose, and then that's the target audience where we're going to go try to improve quality of care. So we used the real-time alert, and we used the patient education bundle, and we showed that this combination of efforts can make a huge difference on missed doses of VTE prophylaxis in hospitalized patients. So this is the visual abstract from the paper we wrote a few years ago. We had some control floors where nothing happened, and there was no change in missed doses. We also had 4 intervention floors where missed doses dropped by about 50% with the intervention. So we now know that it works. So we know it works, and now we moved into the dissemination and implementation rather than the pure research phase. So we got an award from PCORI to continue and grow our dissemination. We grew it out to the entirety of Johns Hopkins Hospital, as well as Howard County Hospital. You've already heard about today a summary of this paper that recently came out about the intervention at Howard County Hospital, and it basically shows that we can use the same real-time alert education bundle and make change at a different type of hospital, this time in a community setting as opposed to a large academic hospital. Similar effect size, the intervention works. So we went back then to PCORI and got another round of funding for dissemination and implementation. And this is a project we worked on or are working on now with the CLOT group, the Consortium of Leaders in the Study of Traumatic Thromboembolism. And that's what I'm going to tell you about for the next few minutes. So here we are, we're doing CLOT 3, and that's our project. So if there's CLOT 3, there must have been a CLOT 1 and 2, and of course there were. So CLOT 1 and 2 was a collaboration between 17 trauma centers across the country, one of which was Johns Hopkins Hospital. And it was funded with about $4.5 million from the DoD, and Peggy Knudsen was the PI. And that was a large prospective observational study enrolled going on about 10,000 total patients that we're actively looking at the data right now. So we took that idea, we took our Johns Hopkins Venous Thromboembolism Collaborative group here. Here we are pictured on top of the dome. This is us. We submitted this picture for our ASHRAM Patient Safety Award winning. And then we combined our group with the group at the Coalition for National Trauma Research, or Center. So Michelle Price is their executive director. Lizette and Amy have been amazingly helpful in getting this project applied for, funded, and underway and working. We have a quantitative evaluation team. So we have a team from the Johns Hopkins Bloomberg School of Public Health that's doing our blinded analyses for the quantitative analyses I'll tell you about later. We also have a qualitative evaluation team led by Peter Kronholm at the University of Pennsylvania Mixed Methods Research Laboratory. We have a huge number of stakeholder organizations. So since 2013, we've been working with some of the large blood clot organizations, in particular the National Blood Clot Alliance and the North American Thrombosis Forum. And those two groups are continuing to work with us now. We've also grown into the trauma sphere with some of the large trauma professional organizations, Society of Trauma Nurses, as well as the Patient Safety Movement, and really brought a wide range of people interested in blood clots and trauma together at the same time. We have two individual patient stakeholders, one of which Leslie Lake spoke at our symposium last year in person on behalf of the National Blood Clot Alliance, and she's the chair of the board, and Vonda Vaden-Bates, who lost her husband to a pulmonary embolism after trauma, and she is very heavily involved in the National Patient Safety Movement as well. So you can come to the website on Center and get an idea of what does CLOT 3 look like. Here's our map with us spread all across the country at our multi-center study. This is the list of the participating centers across the country. So we have things as local, we're here at Hopkins and we're collaborating with University of Maryland across town, all the way across to the West Coast with Oregon and California. And what are we doing? We're implementing those key parts that I've already mentioned: nurse education, the real-time alert, and the patient education bundle. So what does that look like? So the nurse education rollout is actually relatively easy and relatively straightforward. The nurse education is built into the Armstrong Institute website, and anybody can go there and take this education. So we're now going to drive nurses from all of those different trauma centers across the country to take this online education kind of as step one. And here's an idea of what that numbers look like. It is somewhere in the ballpark of over 3,000 nurses will be eventually taking this online education tool at these 10 trauma centers. So we're also going to do this real-time alert rollout. I told you how it worked at Johns Hopkins with the pager. As we work with the other institutions, we're working with their Epic, or in one case, a non-Epic site, to build this real-time alert. It might be a pager, it might be alert with an Epic, it might be a phone, it might be Jabber or Volt or whatever the phone of the day is at each different trauma center. But we're going to have this real-time alert as a part of the intervention. And then we use these patient education bundle materials that we've already created to do the intervention. So you've already heard about what the patient side looks like, but we're also going to focus on teaching the nurses how to do the intervention. Here's an example, and I know you can't read it, but of a poster that's going to hang on the unit and remind nurses of the intervention that's supposed to happen, how they deal with patients. We're going to give them badge cards that they can stick on the back of their badge as reminders and prompts of discussion topics to talk to patients about, why it's important to help prevent blood clots, why these shots are important, et cetera, et cetera. And of course, we're going to have an evaluation phase. So we have a qualitative plan. We're going to get feedback from key stakeholders and a bunch of the frontline nurses. And we're going to do some quantitative analysis, both on the missed doses, VTE events as some of our outcomes, as well as some implementation outcomes, which I'll show you on the next couple slides. So from a data analysis standpoint, we're going to work on the backbone of data already built into the trauma registry at all these trauma centers. So all of the 800 trauma centers across the country that are a part of the American College of Surgeons Committee on Trauma have already a trauma registry, which includes a lot of information we need, a lot of patient demographics, a lot of injury characteristics, as well as all their VTE outcomes. We're going to take that and we're going to link it to some data we pulled directly from the electronic medical record about each individual dose of VTE prophylaxis. Was it given? Was it not given? And why and when? We're going to link those between the encounter number, medical record number, et cetera, to have a large relational database to be able to do our analyses. We're also going to look at some implementation outcomes. And these implementation outcomes are different than the typical quantitative outcomes, but they're important things to think about when you're scaling up. How is this looked at from an acceptability standpoint? Do people like it? Is it well adopted at all the centers? The fidelity, is it done exactly the same? For example, our nurse education should be the same. It's the same online education module. And then important questions about feasibility and sustainability. These are implementation approaches that are important to look at and consider. So after we do this at these 10 trauma centers, what's our next move? We're always thinking ahead, thinking to the next step. And how do we scale this? And the next step is really going to be through the American College of Surgeons Committee on Trauma and the Trauma Quality Improvement Program. So this is where it's important to have a key stakeholder who's heavily involved. And this is from Eileen Bolger, who's the chair of the American College of Surgeons COT, who basically says that assuming this project works on a small scale, they'd be willing to work with us in the future to implement this into all of the trauma centers involved in TQIP. And that's the scalability that we're looking for to help prevent blood clots all across the country. So with that, I'm going to close. I'm going to say thank you very much. And I'm going to open everything up to questions. While you're doing that, here's two good websites. One is from PCORI and one is from the center website to get more information about our project. Thank you very much.